He says it's good. All right, let's get started. Thanks for coming out. Most of you probably know me. I'm Aaron Cohen. I'm an associate professor in the Department of Clinical Informatics and Medical Informatics and Clinical Epidemiology. And this is an Informatics Discovery Lab leadership talk hosted by the department. And I'm very pleased today to host Dr. Daniel Slater, who's a candidate for a faculty position in the department. Daniel holds a PhD in civil engineering from the University of Washington and has received an MBI in clinical informatics from OHSU in 2012. He's currently a senior systems application analyst with the OHSU Pharmacy Informatics group. His interests are data integration and analysis, systems design, and use of informatics to provide more efficient, safer, and effective patient care. His recent projects include participating in the EPIC Willow ambulatory implementation here at OHSU, enabling research access to pathology data, and automating supply chain data processes. His talk will explore how systems integration furthers the triple aim of improving health care and cost and satisfaction by enabling operations-oriented research. Now, I'm supposed to say, number one, that Dan is happy to stay after his talk to talk to the fellows. I guess there was some sort of snafu with the room in the hour before, so if you guys want to hang out afterwards, he's available to that. I'm also supposed to say that we're recording these presentations, so anybody who hasn't been here before, when you have questions, press and hold the touch button while you ask your questions so that they are recorded. And are we live streaming and tweeting today, Brett?
Yes.
And we are live streaming and tweeting today. So if anybody listening on the live stream has a question, they can tweet to our Twitter address, which is, Brett? At OHSU Informatics. And do they need a hashtag? Hashtag DMICEConf. So DMICEConf, right? Okay, and with that, I will give it over to Dan.
Thank you. I was asked earlier today how I came to medical informatics, and I have to say it's just that I asked Google, and Google told me to do it. I don't know if I'd recommend that for everybody, but I was trying to figure out a way to put together some software and engineering and research and public health experience. So I just typed those words into Google, and it kept telling me medical informatics. So my next question was, well, what's that? So 2 years later, I had the opportunity to graduate from the MBI program here, and I've been working at Pharmacy Services ever since. We're lucky to have Joe Fazio, the Assistant Director for Pharmacy Services, here with us. Who I met also at the informatics program. So thank you for this opportunity to talk. First, I'd just like to talk about what pharmacy services, where I fit in here. We sit under Joe Ness, Vice President of Professional Services. Our director is InFam, and Joe is the Assistant Director of Business Services, and working for him is Neil Adillo, my manager, who's the manager of the informatics group, which currently has approximately 17 or 18 people in it. Roughly 6 pharmacists, informatics pharmacists, approximately 4 or 5 application analysts, and then support analysts, computer support analysts, and trainers. So I was originally hired to help with an EPIC implementation for the Willow ambulatory module that was replacing our old pharmacy informatics system, information system. So a lot of the work that we've been doing is putting new systems in place. Our go live was last August, and we're working hard on emerging from that phase and moving into a maintenance phase right now, which we're getting pretty close to doing. In the process of putting these systems together, it occurred to me that we really are furthering the triple aim of healthcare, which is to simultaneously increase the experience of care, reduce costs, and increase population health. This is the framework that IHI uses, and I've circled the red frames are around areas that I think I'm touching on today. All of these, everything from defining what quality is, system level metrics, the individual patients and their families who come up to outpatient pharmacy to get their drugs, the integration of systems to help deliver the product to them, and how that is ultimately going to make this a more efficient and cost-effective process. Now, I hope nobody plays any game that involves counting how many times I use the word system today, okay? But let's just start off with what's the definition. I mean, Merriam-Webster gives a fairly straightforward definition. I prefer the definition that was taught to me by one of the founding members of INCOS, who said basically a system is defined by a boundary. If you can't draw a boundary around it, you don't have a system. I think he was talking specifically about closed systems, just to be clear. So from an analytics perspective, how does the triple aim come into this project? Because ultimately we need to use analytics to understand how we measure things and how we try to improve things. So I've highlighted the objectives that I think come into play in this project. Analytics for improving customer satisfaction, acquisition and retention. We want to have patients happy with the service they receive and come back to the pharmacy for drugs. We want to reduce costs and increase our efficiency. We want to increase revenue and return on investment at the pharmacy because it is a business concern. And we want to optimize our supply chain and human capital management. So we don't want inventory to grow too large. It costs too much. We want to get drugs when we need it. So this is taken from an IBM white paper, and the last graphic was too, of the value of analytics in healthcare. And this is the result of a series of interviews they did with executives. And in the healthcare industry and other industries, the top demand, the top data priority in healthcare is integration of disparate sources. It's going to be a consistent theme that's going to show up in this talk. Other important items here are standardization. How confident are you in the data that you get out of your systems? Healthcare data is dirtier than a lot of people understand. How timely can we get the data in? And can we reduce the complexity of the data so that we can use it? And of course, security of the data. We get orders from all kinds of different places. We get orders from the web. We get people calling in. Web is MyChart, which is also integrated with Epic. We have an IVR, integrated voice response system. So that's the automated message system. You call in with a refill, punch in your numbers, and then the order gets routed into pharmacy. You have external e-prescriptions from external prescribers, and we have a system that connects them electronically to our system. We have discharge patients that discharge orders are signed from the hospital, and they appear in outpatient pharmacy. And we have ambulatory clinics, infusion clinics, where patients visit outside, and they have to be served also. Now, this is a little bit of a misleading graphic because there's this huge block in the middle that says pharmacy. What does that mean? That is a representation of our implementation in August. We have a huge block of orders in the system that we already had that we don't know where they came from, but they were already in the pharmacy system, and they had to be transferred into the new pharmacy system. So that gives you an idea of the relative size of legacy orders and new orders. This data set covers, the data set I'm talking about will cover October 2012 through February, October 2013 through February 2014. All right, so that's the time frame we're looking at here. So I'd just like to take a walk through a number of the systems that the pharmacy uses to connect to the outside world. And this is really kind of will give you an idea of the complexity of the project that we had to undertake during our implementation. Just feeding orders into Epic, the shaded areas, the light shaded areas, and I'm sorry the color doesn't show up as well here as on screen, but the light shading is existing, and the darker shading is new systems that we had to modify or implement. So we have on the left all the sources of information. E-prescribing from Epic, the IVR, the external e-prescribing, telephone, fax, and written walk-in. All of these interfaces needed to be reworked. And of course, the Willow ambulatory module was a new interface itself. So now we have systems for getting the drugs out of our information system and to the patients. So again, we have Epic as the source, and we have an interface between every endpoint. There's an interface between the dispensing robot, which about half of the larger operations volume gets dispensed through. Very important interface. The most important interface is probably with the insurance switch. This is how we find out if patients can pay for the drugs. Insurance covers it, real time. We have a separate print server that's just for pharmacy printing. Separate interfaces for the sales till and the will call storage cabinet. And we also have a drug information database that supplies medication monographs and images and descriptions of drugs that get printed out along with the prescription labels. Will call storage cabinet is, they have some automated storage cabinets where when the prescription is ready for pickup, it gets stored securely. When a patient finally walks up, it might be the next day, it might be a week later. The prescription is removed from the storage cabinet, and that's how it's stored. We also have to order drugs from our supplier. How do we do that? We have another set of systems for that. The user creates a file that gets deposited on Epic's native server. Then it gets transferred by an information technology utility to a Windows location where the end users can access it, and then it gets uploaded to the website. So that entire system is new. That didn't exist before. And we also have a system for tracking drug purchases, and this is all new. So this is a lot of the work that I was doing over the implementation period. It turns out that there's something called the 340B drug program. I don't know if any of you have heard of it, but it's a pricing program that allows hospitals like ours to serve indigent patients who can't pay for drugs. And it allows you to buy back drugs at tremendous discounts from manufacturers. But you have to track which prescriptions are eligible to be replaced at this low price and which aren't. This is worth millions of dollars to the pharmacy, and if you get it wrong and you're out of compliance, you can be yanked from the program and lose all that. So it's pretty important for a pharmacy to get that right. So it looks fairly complicated, but the reason I'm showing this is that ultimately this is an example of how sometimes you have to take multiple considerations into account when you design a system and you write a program. In this case, we have a situation where Epic had a delay in supplying their 340B tracking software, and they couldn't deliver it in time for our go live. This is a huge record-keeping problem for pharmacy. Pharmacy processes approximately 1,500 prescriptions per day. And I devised a system that allows us to track the difference between what we buy and what we sell and determine which prescriptions are eligible for the program, the buying program. And I put that in place as a stopgap measure until Epic can come up with their module. Okay? So this part here, this accumulator is what we call it, the tracking software. This part here and this part here, I wrote, this has a lifetime, this part has a lifetime, design lifetime, of only about 4 months. It's designed to be just meet the minimum requirements that we have and then be thrown away and replaced with commercial software. Because a team of people working for years on a product is going to put a superior product in place to anything I can do in 500 hours. There's just no way around it. But it's functioning as a stopgap measure right now. Kind of works well enough for our purposes. I'm very eager to have them put the commercial product in place, so I don't have to support this anymore. So, but there's a separate part going on here. These are invoices from our drug supplier. How are we going to know what we purchased? The existing system involves people, when they get the time, going up to a website and manually downloading invoices, putting them into a spreadsheet, and trying to do analysis on that. It's very time consuming, and it doesn't always happen. People have real jobs. They've got lots of other demands on their time. So it's a challenge for people to do that consistently. So the system that gets set up here is a daily feed from the drug supplier. That's the top where it says X12 invoice. This is a coded format. It gets transferred through an ITG system through a secure server from the external supplier to our internal system, where there's this component, this parser, uses it to keep track of purchases against the dispenses and keep a balance of what we're eligible to buy back for 340B. But there's another value here, because pharmacy has a different need. They need to keep a running record of their purchases. They have to be able to analyze what they buy in order to keep their costs down and to know whether purchasing is, if there's a problem or not. So this part here, this purchasing record, is a separate file that has a completely different value than what the accumulator has. That has a different design lifetime. So that's probably going to be about 1 to 2 years lifetime, because we're trying to integrate that information into our enterprise system. At that point, we can probably do away with my homemade parser. So you have a system that has multiple parts. Each part has a different lifetime, and it's all designed to ultimately be replaced by something else. Every system has a finite lifetime. So just a couple of these ideas for designing systems for change. Involve decoupling. Things have to be able to work in independent parts. Standardized interfaces, so that if you take out one part, you can plug in another one and you know it's going to work. Standardized content. You have to look at multiple stakeholders' needs. In the case of our previous system, we had a billing system to get invoice data into our billing department. But it was the billing people, all they needed was the total amount of each invoice. They didn't understand that pharmacy has a separate need for knowing what is in the invoice. What are you buying? What kind of drugs are you buying? And that's what that purchasing record replaced. It took an existing system that met one stakeholder's need with a system that meets multiple stakeholders' needs. And now, more stakeholders within pharmacy are starting to call and say, what about that file you're keeping? Can I have access to that? And that's what ultimately is going to prove the value of anything that you put in place, is if people start coming around and asking for it. So I'm not done with systems yet, right? So there's like a whole bunch of these small systems that feed into larger systems and still into now systems that report information out to end users so that they can use it. We have this is from the clinical informatics reporting team. I've copied their slide. Thank you very much. This is sort of the reporting system that's in place right now at OHSU. You have some reporting workbench straight out of Epic's backend. That's Cache. You have a daily extract, transform, and load into Clarity, which is the relational database system that sits outside. You have the data warehouse that has a separate extract, transform, and load system, and various reporting tools that come from these different sources that people use. Why do I care about this? We have built, if I don't care about this, we've only built a silo in terms of that purchasing data. We have to figure out a way to get financial data and purchasing data from pharmacy streams, separate pharmacy streams on the left, into the OHSU data warehouse so that we can combine that information with the overall enterprise and then use it, in an integrated fashion. So that's a current project that we're working on. That's, I don't know, that might take a year to 2 years to complete that. That's why I said the purchasing report has maybe a 1 to 2 year life cycle. Then that'll be put away and an enterprise system will come in place. Now, a friend of mine at ITG jokes with me and says, I tell him, I don't write enterprise software. He says, well, they're using it, so now you do. But that just scares me, so I try not to think of it that way. So I just want to take a break from all this systems talk. That's a lot of information about many different systems, but it gives you an idea of, the complexity of the healthcare enterprise and how things have to fit together in different considerations. So you've all seen the HIMSS EMR adoption model. So I just want to take a break, take a look at this. Where are we? Where are we? I think we have closed loop medication administration inpatient. So that's stage 5. We have some structured templates that we're putting in place through pharmacy, and there may be some in other areas. I'm not familiar with them. I'd say we're probably at least stage 6. It's my guess. I don't know if other people think differently. But there's a difference between having systems in place and actually using them to do something. I mean, besides patient care, but I mean, what are you going to use them for? So back from this white paper that IBM put out, and this is from a joint study with MIT Sloan Management Review. I think this is a really good graphic that kind of talks about not the systems, but what you do with the information that comes out of the systems. Because that's the next step, really. Otherwise, we're just building computer programs. So the way they divide it up is aspirational, experienced, and transformed. And I'd like to kind of frame the rest of the talk in terms of these different stages of how we use analytics. So my interpretation of what that graphic says is that Aspirational use, you want to use it, but the lack of systems integration makes using it too cost prohibitive. It's difficult to use the systems you have. So we want to do it. We aspire to do it. So just for an example, I'll present some data comparing turnaround times at 2 different operations, all right? And this is from before we put the new system in place. It was very difficult to combine the data in a way that we could efficiently make use of it. We have different operations with different workflows. There are a lot of different definitions of turnaround time. There's lots. But if you want to compare across different systems, how are you going to do that? Are you going to have to use different metrics, or can you come up with a metric that lets you compare 2 different systems? We have, at the top, we have outpatient pharmacy. The first 2 steps are the same as central fill pharmacy. Patient calls in for a refill. In the pharmacy, it gets filled and verified. But for central fill, they ship it out 1 time per day, 3 p.m. For outpatient pharmacy, they can put it in the will call cabinet, and who knows when the patient's going to show up. How do you know, what's the actual difference between getting it to the patient from the time it comes in? Well, come up with your own metric that reflects that. Let's say, take the number of business days to ship from central fill, the number of business days to will call and sales, in number of business days to the will call system. So that's actually the time that the central pharmacy, the outpatient pharmacy, puts the drug in will call and it's available, which is the real endpoint, because the patient could come up any time. If you wait for the sales till to ring, that's not an accurate representation of that turnaround time. Don't include weekends for one operation. They don't work on the weekends. So you have to put together a bunch of different systems. You have to put together data from this voice response system that's not connected to your pharmacy information system, and then the will call system, which is separate, and then join them up together, and then you can calculate your turnaround times. That takes a lot of effort. That's not really a tenable way to produce analytics on a regular basis. It takes too much time. But just for example, we did it, and turns out that I can tell you some interesting things. In this example, I broke it down by what day does the customer call the order in. Does that make a difference in terms of how long it takes for the patient to get their drug? Well, kind of does. The blue is for mailing out, shipping out. Most of the orders come in, the refill orders come in over the weekend. There's a lot. So on Monday, there's your peak turnaround time. The people who call in on Saturday have the lowest turnaround time. This is business days. So in reality, if somebody calls in on Saturday, the clock doesn't start ticking until Monday. Monday is 0 for the first day. Tuesday, about Tuesday, the order gets shipped out if you call in on Saturday. If you call in on Monday, your order gets shipped out sometime around Friday. That's not too bad. But look what happens. You still have like a 4-day calendar time difference. So that's fairly consistent. But look what happens if you call in for shipping, for pickup. If you deliver things. If you call in an order to get delivered to your pharmacy on campus from Central Fill on Thursday, you're waiting until next week. But if you call in your order to get it delivered on Friday, it's probably going to show up the next day. That's interesting. So we give this information to operations so they can go over it and make changes, change their staffing if they have to, look at the way they process their orders. It's actionable information that they can use to improve their operations. If we look at the other outpatient operation, wow, look at that. Everything pretty much goes out the same day. These are people who are getting discharged from the hospital. They come by to pick up their meds. They, they call in their orders. Some walk-ins, people just walk up with scripts in their hand. So this operation tends to get things out same day. This here, sometimes they put together an order and they ship it out to central fill for mailing out to places. That's an anomaly. That 7 is an anomaly. There's 4 particular orders that had special circumstances around them. So that's a small data set that's not really, it's an outlier, I would say. But you can use this metric to compare different operations, IVR into the will call coupling, and look at how things vary, how you might want to adjust your operations if you want to smooth things out, make changes. But it takes a lot of time. This analysis took a week at least to figure out how to get the different systems together, join up the data, produce something that was actionable. It's just not possible to do that on a regular basis if you've got an implementation going on. So I would say that's kind of an aspirational stage of analytics. We want to use the data. It's hard to get to. We can't really use it on a regular basis. So what about the next stage, the experience stage of using analytics? So let's use these systems that we put in place. Let's use the integration to produce data. Information, not data, information. We're working on putting dashboards in place, but they're not fully implemented yet. That's sort of this current stage of the process that we're in. We're still implementing the full capability of the integration. So, I would say that I think that we're emerging from the aspirational stage and trying to enter the experience stage right now. That's where pharmacy is at. And we'll get there. Whoops. So, I took the opportunity of this talk to give myself a little kick in the pants, do some data mining, and start looking for some patterns. Sometimes we can't give a complete drug fill to patients because there isn't enough stock. We call that a partial fill. I was thinking, well, if we have the highest volume days, you would expect that there would be more partial fills because you might not be as ready for the demand. That doesn't really show it. This is a pretty weak relationship. Yeah. This is a pretty weak relationship. I have to keep looking. Questions are, why is there no relationship or little? Well, it turns out that there's other information that suggests that inventory is growing too much at pharmacy, which would help explain why there doesn't seem to be much of a correlation between how much volume you have and what % of your orders are partial fills. Possible. It's just a suggestion, but it provides a background of what's going on. I'm trying to understand right now also why there seems to be a higher rate of prescriptions that get canceled after they're filled and waiting for patient pickup. There seems to be a higher rate than some people think there should be. Why is that? Is that connected to partial fills? Still have to do more data mining to find out. I wish I had that data for you, but I don't right now. So what's the next stage after this? You know, we're still trying to enter the experienced analytics stage. Well, the next stage is transformational. How can we advance knowledge? Can we predict demand before it happens? Can we predict it well enough that we can buy less drugs ahead of time until we absolutely know we're going to need to? And what about transitions of care? Patients going home, getting discharged. How can we use our data to contribute to research in that? These are important areas with continuity of care, continuity of care, possible readmissions. We need to be able to connect this information. Is there an optimum level of partial fills and out of stocks? If you never have a partial fill, you'll have a bloated inventory. We don't have unlimited money. We don't have unlimited space to store thousands of products. So you have to try to limit your inventory. This is a classic operations research question. How do you make a trade-off between maximizing patient satisfaction and minimizing inventory costs? Can we reduce inventory costs and increase patient satisfaction at the same time by predicting drug demand for discharged patients? So I would say this is a classic operations research question that I would love to be able to answer. But first, we also have to make the business case for whether it's worth answering. How much is it costing us to not know these things? Pharmacy is dependent on multiple factors. One person I know is fond of saying pharmacy is a dependent variable. You know, patients discharged from the hospital, they want to get their first fills of a drug. Pharmacy is totally dependent on a lot of factors. How many patients are getting discharged? What are their conditions, their clinical units, what procedures? What are their trends? What are the trends in prescribing? What percentage of people choose to use the pharmacy instead of going to Walgreens? So if I were going to start looking into this as a research problem, I'd start looking at, you know, what is the volume of drugs dependent on? VI here should be QI to match the QI up there. Quantity. I wanted to say quantity. Sorry about that. So the quantity of drugs here, I'm proposing that it's a function of the expected volume of discharges for a given condition on a given day, the percent of patients with that condition who are prescribed that drug, percent of patients who choose the pharmacy as their pickup location. It's a very simplified version of what kind of functional dependence you might expect. Now, different components of this are already in place. OHSU has an expected discharge number that they publish. I don't know how they get that number. I have no idea. Other people have done research into this. Here's an example of a scoring system to predict how many people are going to be going home. So you can certainly use these kinds of models as input into a demand model. You also have people working on inventory allocation. And this is a classic operations research problem. It's in a lot of industrial engineering literature. It's mostly on the inpatient side here. This is just an example of, you know, the blue is the current hospital model. It's not OHSU. This is from a research paper. Different hospital. And then some people used operational research techniques, modeling techniques, to come up with two different models that show, well, you can actually reduce your inventory significantly if you know what factors to look for. So ultimately, I think, you know, as far as outpatient pharmacy goes, these are the kinds of transformational analytics that are going to change the way the business operates. We still have a little ways to go before we can get there. There are a lot of questions to be asked. How much do we pay for the drugs? How much do we get reimbursed? Do we have too much or too little inventory? What are the costs associated with low patient satisfaction? When do your patients turn away and go somewhere else? Are we buying efficiently? Patient satisfaction questions that need to be asked. How well can we deliver the drug when the patient wants it or needs it? Why are fills canceled at a relatively high rate? Do partial fills have different refill capture rates? You have a first fill, but you have a series of refills after that. If your patient's not happy and leaves, you miss a whole stream of refills down the road over the next several months. That's a lot of cost. That's a lot of revenue walking out the door. What factors drive patient satisfaction? These are all some of these are connected. And of course, quality questions. Does the patient get the correct prescription? Medication dispensing error questions. So I think these are all areas that we need to understand better in pharmacy. That I think that these are areas that need to be understood better, that are opportunities for using analytics to improve our business and give a better patient experience at OHSU. So returning to this, where is our current capability for using analytics? I'm putting us somewhere around here. That's just my own personal opinion from what I see. And how are we able to transform this problem and the use of analytics to achieve all of these things? We talked a little bit about, designing metrics to suit what you're trying to measure. The individual patients that are involved trying to get their drugs, the integration of systems that allows data to be put together efficiently and used in a way that ultimately we can reduce the per capita cost. How can we provide better quality health care at a lower cost? And I think systems integration enables analytics, and then development of analytics ultimately enables this goal. So thank you. That's all I have. Any questions? None. Yeah.
Curious, to what degree are your interfaces dependent on the designs of other systems? Because, if Epic decides to change how their module functions, then that sort of dumps a bit of a workload on you.
Well, we actually, so the IT group has a dedicated interfaces team, and they've become our friends. As a matter of fact, well, you've seen how many interfaces we have with the outside world. So after our implementation was finished, our team took the interfaces team and the printer guy out for a beer, because without them, we definitely couldn't have done this project. There's at least two different kinds of interfaces that Epic uses. They have a web services interface, and I believe a more traditional TCP/IP interface. And I should really go and check on that, because I don't want to give you wrong information. But there are two different main kinds. I know one of them is the web services interface. What do you mean when they change?
I suppose I was curious as to if, they add new functionality, they may add, a new function call in their web interface, and then you'll have to either incorporate that into your system or not.
So the interfaces that we use usually come with pre-built functionality. We don't get to do anything to the interfaces. We have to work with the vendors to make sure that any upgrades done on one side are compatible with the other side. So sometimes we have Epic and the vendors work together to make sure that if they're changing, one side is changing their system, they'll continue to work. Yeah.
Have to hold the button.
Yeah.
So could you talk a little bit about the process and what it might take to move some of this stuff into the data warehouse that you're talking about, and therefore make it integratable with the other data for asking questions in analytics? What does that look like without telling any tales,
Yeah. So the data warehouse has a number of data marts that are associated that serve different departments at OHSU. And currently, pharmacy does not have its own data mart. All right? So part of the process of integrating this is the process of creating a pharmacy data mart, ultimately. There's an entire business intelligence team that governs the data warehouse and the extract and transform and load system. So we can only take it so far. We can prototype how to do it. We're in the process of prototyping a data mart, but we have to do it with the cooperation of the business intelligence team to understand what their data model is. So if we build something, it has to be ready to be moved into the other system. And this is a long process. So I don't know if that really answers your question, but it involves working with the business intelligence team and divvying up responsibilities between which team does what. We can prototype things up to a certain point, but after that point, we have to coordinate with them how to get it into the enterprise system.
So you're going to have to move over some of these ETL steps that you've already built. I mean, there's some, very particular data capturing, that's sort of outside the ITG scope, at least initially, until you shove it in there. Are they going to inherit that, or they're going to have to do it their own way, or, how do you envision this moving forward?
I think that business intelligence is asking the same questions, and we are too. So we're in the beginning stages of, we have a data model, and we've just gotten approved for a database to do prototyping in. And the next step is we have to coordinate with business intelligence and talk to them about how to do this. It's really more their area of expertise than ours. So we don't want to waste effort. We don't want to do things that get thrown away. And we don't want to do things that are at odds with their design philosophy either. So it involves close coordination. I don't know the technical details yet of your question, but that's an excellent question. It's the exact questions that we're asking right now. Thank you.